So, Assalamu alaikum wa rahmatullahi wa barakatuh. Again, good morning. Today we'll start our session. It's a collective session about the structured discussion tasks. Very important session. And we'll start with the first task, which is highly requested. The acute kidney injury after surgery. Very important task. This task has come in the exam so many times in different scenarios, but the answer will be almost the same. There are so many important points in this task to put in your mind, and you will easily pass. This task, according to our turn, will go for Dr. Alia. Dr. Alia, are you there?
Yes, sir. Good morning.
Okay. Dr. Ali will be with you for this task. You will have the 2 minutes as usual to read your task. Then, exactly as in the exam, Dr. Ali will come out with his camera and he will start asking you. Go on. Dr. Rehana, please close your camera. Close your camera, Dr. Rehana. Dr. Ali, please open your camera. And you will have 10 minutes now, Dr. Alia, for the discussion. Today, you will not give any extra second for anyone. It will be a mini exam, exactly like a mini exam. Go on.
Hello, I'm Dr. Alia, and I'm ready for the discussion.
Hello, you have read the case, right?
Yes, yes, sir.
What is your diagnosis?
The possible diagnosis based on the investigation that have here and from the assessment that has been done. The possible diagnosis that I put in my mind that this is a case of sepsis and acute kidney injury and maybe anaphylactic reaction to medication and anesthesia complication and anemia.
So what do you think is the contributory factor to this clinical picture?
This is a case of primary gravid twin pregnancy for elective cesarean section. The contributing factor from the given information that I put from here that maybe there is reduced fluid intake pre-op because of dehydration and maybe because of a decreased intravascular volume because of this is a case of twin pregnancy and there is underestimation of blood loss intraoperatively, post-operatively and intraoperatively, and inadequate fluid replacement during the post-operative period.
If I told you that the cesarean was done for twin first breech, and during the antenatal care, she has mild preeclampsia that was not on antihypertensive, and her operation was scheduled at 9 a.m., but for emergencies, it was postponed till 4 p.m. And during the operation, there was a blood loss around 1.3 liter that respond to uretonics. Is that change your view about the contributory factor?
From the information that has been given, because of the prolonged period of the delay of the surgery, and since she's a case of preeclampsia, and that results in reduced fluid input during the period of starvation, that might put her at higher risk of having kidney injury because of all these circumstances, because of the PPH, because of she's a known case of preeclampsia and prolonged starvation.
What abnormal in the results you have?
The information that the HP is low and also it's reduced in the second result. Her white PC is high and has increased also. Her potassium level is high and the GFR is low. Also, the T-reactive protein is high.
You want to involve anyone in the management of this case?
Okay, since this is a case of suspected acute kidney injury or a case of sepsis, her care should be under a multidisciplinary team. This will include the consultant, it will involve the nephrologist because of the result of the renal function test and the anesthesia and the ICU specialist and also microbiologist. And this case needs to be admission in HDU, high dependency unit. I need to involve the patient and the family and inform him about the possible diagnosis and why we admit her. And also we start immediate action by sedating this patient and first do urgent ECG to assess because of the hyperkalemia, because of risk of sudden cardiac arrest and immediate management for this. And also need to arrange for the serum lactate and arterial blood gases analysis, and also do a high culture swab and culture, taking high vaginal swab and urine culture and blood culture because there's to check for the antibiotic response, and then put patient fully catheter to monitor fluid input and output, and put her on continuous monitoring for vital sign every 15 minutes, and need to also strict management for the input and the output by measuring the arterial line, central venous line. And for the pain management, try to avoid non-steroidal because it's nephrotoxic and might affect the kidney injury, and avoid the potassium-rich fluid, and do urgent assessment for the patient for venous thromboembolism risk assessment, and breastfeeding can continue as usual, and start her on antibiotic as that is not nephrotoxic because of risk of increase the involving kidney injury. And also check for the patient if she has symptoms for anemia like having lightheadedness or weakness. To start her, if she has no symptom, we can start her on oral or IV iron for the management of the anemia.
The ST2 uptight repeat the labs. He thought that there was a lab error, so he repeated the labs. Is that a wise decision from him? and what you are going to do about that.
First, the ST2 have not noticed that there's hyperkalemia, and this is an emergency situation. So I need to do a constructive feedback with the ST2 and do a reflective practice to know why he missed this information and why he didn't communicate about this information. And do a full the incident report form because this is a near-missed incident, and to avoid this complication from happening again.
After this patient being treated and discharged, you need to follow her up.
Yes, because of this is a case of acute kidney injury, then there's a possibility for the patient to develop a chronic kidney injury. So I need to do a follow-up appointment with the consultant in 2 to 3 years after discharge to exclude this possibility and to maintain the patient safety.
With whom you want to have the follow-up?
With the consultant nephrologist and to check for and repeat the investigation and do ultrasound for the scans for the kidney to exclude this possibility.
Can you summarize your initial plan again, please?
First, I will do full assessment for this case by taking the history from the pre-op and intraoperative and post-operatively, and do full investigation for this patient by doing ECG and taking serum lactate and taking blood sample and liver and renal function test and do ultrasound to exclude any hematoma or any collection. And then I will arrange for a multidisciplinary team meeting to put the patient under care and transfer her to HDU and urgent management for the hyperkalemia, correction for the hyperkalemia, and put her on continuous monitoring every 15 minutes and start her on IV antibiotic as soon as possible to prevent the sepsis, the possibility of sepsis, and also continuous monitoring of fluid input for this case.
Any advice you will give the patient?
For the patient, I will advise her that in second pregnancy, she is at risk of developing also preeclampsia to continuous follow-up. I will encourage her about movement to exclude, to prevent the risk of having venous thromboembolism, and advise her if she develop any unusual symptom or any unusual discharge to come immediately. And if she develop any bleeding or pain to come immediately.
Time, Dr. Bushra, please close your mic. Dr. Bushra, take care. Close your mic and your camera. Your camera also, please. So, Dr. Ali, now you will have your evaluation from Dr. Ali.
Dr. Ali, you have done it very well. This station actually very few that pass the 4 domains for this case. It's a very important case, as Dr. Sour said, because it full of data and need the organized person to pass this station completely. Regarding, I will start by the feedback, then I will give the general impression. Regarding the safety, you passed the safety because you mentioned that there is hyperkalemia and the risk of hyperkalemia. You involve the ICU doctor and the anesthesia doctor. You avoid non-steroidal anti-inflammatory drugs. You mentioned about the follow-up and you recognize the acute kidney injury. These are the safety points that you mentioned them all. So you pass perfectly the safety in this case. In the communication, you have got borderline, although you almost said all the cases, all the things, but one was planned to have an asterisk or to have a borderline mark if you are not mentioning, and I prompt you, but unfortunately you didn't get it. In the communication, you communicate with the colleagues and you ask for the lab results and the urgent CTG culture, the lactate, and you discuss the management well. And you mentioned that there is no need for transfusion. But regarding communication with the patient, when I ask you, you want to advise the patient anything, there are 2 points. You know that there are 6 B's after postpartum. This one, the points that mentioned are regarding the breastfeeding. She can continue breastfeeding, and to advise her to avoid potassium-rich food. I know this point is maybe away from our own minds, but it has a point in the exam. So it's very important to communicate the patient this advice. Regarding the information gathering, you pass. Although you are prompted at the end. While I ask you about the diagnosis, you jump, as most of the people, to sepsis as a start, but simply you can say that it's a case of postpartum pyrexia, hyperkalemia, and evolving anemia and evolving acute kidney injury, and I need further informations and investigations to reach the proper diagnosis, but I have in my mind a sepsis, anaphylaxis, dehydration, and other differential diagnosis. You mentioned the information gathering. You should ask me about the antenatal events, the antenatal labs, intrapartum and peripartum events, and at that time I will give you the data that I give after you finished your answer. So before giving the full diagnosis, ask about the further data, because not all the data mentioned in the scenario. So in the information gathering, you pass because they are all borderline points and you mentioned them even after prompting, but collectively you pass in the information gathering. Regarding the applied clinical knowledge, you pass, you identify the hyperkalemia, the anemia, the fever, and the near miss event. You order for urgent ECG and put the catheter, restrictive fluid balance. You mentioned about the monitoring, HDU, iron therapy, incident reporting, and constructive feedback to the night on call, and venous thromboembolic risk assessment. So in the applied clinical knowledge, you pass. So you pass 3 domains and only borderline in the communications. And collectively, if I was the examiner, I will try to pass you also in the communication because you pass most of the station well. The issues in this case, once I ask you what is abnormal in the lab, the usual candidate will tell one by one the hemoglobin is low. He will read it, but we don't want that. I want you to know that to give me the meaning of what you are seeing. For example, here the most serious one is the hyperkalemia. So you will say that there are some deranged results. The most important is high potassium, which need urgent interference. The hemoglobin is low, but I need to know the pre-operative hemoglobin and is there underestimation of the blood loss or ongoing blood loss. Presence of inflammatory marker higher support my suspicion of being a sepsis. So these are simply, and they have regarding the renal functions. I found that the kidney function is starting to deteriorate. So I should keep in mind that, and I should involve the nephrologist in the management of this case. When I ask you the initial plan, first, when you see a high-risk case, mention that it is a high-risk case. It gives me the impression that, you know, this is a serious case. It is not a simple one. So before going through the steps of your management, just give me the impression that you know this is a high risk case. The initial plan will be in the form of to review the antenatal notes, operative notes, and post-operative charts, and to examine the patient looking for symptoms of anemia and presence or absence of the catheter, and to explain her condition and the need for further tests, and communicate the plan. And while communicating the plan, you have 4 points. The potassium, regarding the high potassium, you will need the high HDU monitoring, food advice, urgent ECG, strict fluid balance. Regarding the anemia, you will give oral or parenteral iron. You avoid blood transfusion because of 2 reasons. One is the patient is asymptomatic, and stored blood will have much potassium, so it will be risky in this case. Regarding the fever, antibiotic already mentioned, given by ST2, but you will involve the microbiologist for to continue the same antibiotics or different one. And you send already the lactate and culture. And regarding the acute kidney injury, you involve the nephrologist, avoid non-steroidal, and you can use instead of non-steroidal the paracetamol or opiates for analgesia. So by that, you will completely cover the case. You need to have, you have any questions, Dr. Alia?
No, sir, thank you very much.
Well done in this case. Only give me the impression that this case is high risk, and don't miss that in the structured discussions. Many times the examiner will have a data that will give you. So don't hesitate to ask about this data. Thank you.
I have one question, Dr. Ali. Dr. Ali, did you mention specifically the ECG or no?
Yes,
I mentioned it.
Okay.
ECG, yes.
Yes, this is very important in this case. So thank you, Dr. Ali. Thank you, Dr. Ali. Only because of the sake of recording, and this task is highly requested by each one, I will go quickly through the slides, because Dr. Ali, we will take your permission, please, to publish this station. You did very well. So we have to put it for the free group as a sadaqah, if you don't mind. Dr. Ali, close your camera, please. So how to review and interpret the result and correlate with the clinical picture. This is the point Dr. Ali told you. Correlate the result and say a diagnosis of the result. So this patient has anemia, this patient has leukocytosis, hyperkalemia, increased glomerular filtration rate, and high C-reactive protein. So as usual, as we used to do, putting in mind the possible differential diagnosis, what are the further information you need to know? You need to know further information from the history, from the examination, and some more investigation. So further information means history, examination, and investigation. From the history, most important here is to review her antenatal records. Because this patient has preeclampsia, so you have to go and check the blood pressure reading, and at booking and in the repeat visits. The full blood count for anemia, liver and renal function test, if there was evidence of Crohn because the patient is in sepsis, and if there is any form of infection, whatever the source of infection in a case which is postpartum. Very important to ask around the circumstances around the cesarean section. So if there was pre-operative hydration, the intra-operative events, the post-operative, so the pre-operative hydration, the surgery was delayed. So here, as Dr. Ali told you, you have to ask, you have to get information from the examiner. You will not get this information unless you ask the examiner about the possibility of delay or improper hydration before the surgery. What type of anesthesia? Because there are some types of anesthesia which are hypotensive anesthesia. Intraoperative events, again, the anesthesia, the surgical steps or complication, and the type of antibiotic and the amount of estimated blood loss. Post-operative, oral and IV intake, if there was any nausea or vomiting, the input and output chart, if the urinary caster is still in situ, review Hermuse chart, history of palpitation, weakness and lightheadedness, pain or vaginal loss, bowel or bladder symptoms, breastfeeding pain and engorgement. Again, here, as Dr. Ali advised, these are the 6 B's after surgery. So you have to ask about these points also. Any respiratory symptoms and the COVID. Ask about the COVID if the patient, even pneumonia. If the patient, we are still in the COVID era, so please don't forget to ask about the COVID. The ambulation, leg pain and swelling, there is possibility of pulmonary embolism and re-evaluation of the thromboembolism risk. So these are the information you need to know from the history. Information means you need to know about the examination and the investigation. Dr. Rehana, close the camera, please. The examination, general examination, abdominal examination, and vaginal examination. So this is the point to be organized during the discussion. Always mention the headlines at the start, then go to the sub points. So general, you need to know about the conscious level, signs of anemia and dehydration, vital signs. You have to examine the breast and the nipple and legs for pain and swelling. Abdominal examination, you need to check if there is any tenderness or rigidity, if there is any distension, if there is any collection or hematoma. You have to examine the renal angles and the examination of the scar for any redness or swelling or signs of infection or hematoma. For vaginal examination, you need to estimate the amount of blood loss, abnormal discharge, and the vaginal swabs. Most important in the investigations, ECG, and you already mentioned the ECG because the patient has hyperkalemia. This is a critical point. Ultrasound scan to check if there is any hematoma or collection. X-ray of the chest and the abdomen for infection and for any possibility of obstruction. Cultures are going to manage a case of sepsis, so you have to take all cultures, liver function test, urea and electrolytes and coagulation screen, and serum lactate. It has to be measured in any case of sepsis, arterial blood gases, and you may even need to do CT, abdomen and pelvis. So the differential diagnosis in this case, always be open, Dr. Alia. Don't go immediately and mention about the acute kidney injury. The most probable diagnosis here is this is a sepsis. Post-operative pyrexia, possibility of sepsis, may be due to dehydration and electrolyte imbalance. It may be due to anaphylactic reaction to the medications or anesthetic complication or evolving acute kidney injury. It will be better if you say evolving acute kidney injury. Yes, there are the potassium level is high, the urea and electrolytes, the glomerular filtration rate, but still the creatinine is within the normal limit. So it's better to say evolving acute kidney injury. What are the contributing factors? You will not get these factors unless you ask Dr. Ali. And Dr. Ali, he told you about the information in this case. So now you know that this patient, the surgery was delayed and she was waiting and she didn't receive proper fluids in the pre-operative period. So low intravascular volume due to preeclampsia is one contributing factor from the history. If you didn't ask the history, you will not get this point. Prolonged starvation in the pre-operative period, if you didn't ask again, you will not get this point. Underestimation of the blood loss at delivery, this patient has bleeding intraoperative, so you will not get this point without asking. And inadequate volume replacement in the post-operative period. Management plan, in any emergency situation, you have to emphasize or you have to stress that this is an emergency or a critical case. In any emergency or critical case, we already mentioned before, in any emergency, communication, resuscitation, investigation and monitoring and management. So communication, again, resuscitation, investigations and monitoring, then the management. So how to communicate, who will be included, the multidisciplinary team management, you already mentioned all of them, the patients and the families who have to explain results in a simple language and the further investigation. This patient will be admitted to the high dependency unit. And I previously mentioned, if you are going to send the patient to high dependency unit or ICU, please inform the family and ask the patient if she needs to inform or call someone. Resuscitation, what's urgent? Urgent ECG and immediate management of hyperkalemia because this may lead to cardiac arrest. Insertion of urinary catheter, if not there, you have to Do strict fluid management, input and output chart, frequent observation and abuse chart, prescribe antibiotics according to the microbiologist, and avoid the nephrotoxic drugs. These are points which are very, very critical. If you are going to give pain relief, give opiates and avoid non-steroidals. Avoid potassium-rich food. Give oral or IV iron. There is no need for blood transfusion here, as the patient has no symptoms of anemia from the history, BTA and thromboprophylaxis, and the patient can still have breastfeeding and follow the infection protocol measures. This is a case of suspected sepsis, so we have to follow the infection protocol measures. How to avoid this happening in the future? Again, this is a post-operative case, and we already mentioned before that in any post-operative case, you have to complete the 7 Ds. The 7 Ds post-operative: debriefing, documentation, duty of condor, statics, drills, and the discussion. So what's going to happen here? Discussion. Proper hydration. How to avoid this happening in the future? By proper hydration of the patient before surgery. Complete an incident report. This is a near miss incident. The ST2 did not identify hyperkalemia, which may lead to death of the patient. Provide constructive feedback and reflective practice. Ask the ST2 why he did not recognize hyperkalemia. Then ensure follow-up, and the follow-up here will be with the consultant and with the nephrologist because the patient may develop chronic kidney disease. This is the way how to answer this important station. You did very well, Dr. Alia. I think Dr. Ali guided you to the points you need to improve. Very well done, and thank you so much.